All right, good evening, everyone, and thank you for joining us tonight. We'll start with a few housekeeping items, and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it at the chat box in the lower part of your screen. We will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Patrick Selph of Urology Associates. Dr. Patrick Selph is a native of Franklin, Tennessee, and joins Urology Associates after spending 7 years as an associate professor in the Department of Urology at the University of Alabama at Birmingham. Dr. Selph attended the University of Virginia and earned a Bachelor of Science in Biochemistry. He completed medical school at the University of Tennessee College of Medicine in Memphis. He then completed his general surgery internship and urology residency training at the University of North Carolina in Chapel Hill, North Carolina. And he didn't have to travel far when he followed his residency with a fellowship in genitourinary cancer survivorship at Duke University. Dr. Selph brings specialization in complex reconstructive urologic surgery to Urology Associates. He specializes in both robotic and open urologic reconstruction, artificial urinary sphincters, and penile implant surgeries, urethral stricture, and managing complications of all types of pelvic cancers. Thank you again for joining us tonight, and now I'll turn it over to Dr. Selph to get us started.
Thank you. Thanks very much for the introduction, and appreciate everybody being here tonight. It's maybe one of the few nights in the last month where you don't risk death going outside, going for a walk because it's so hot. So I appreciate you spending it inside for a little bit and hearing about the talk tonight. So our goal tonight is talking about male stress urinary incontinence and understanding the causes of it, as well as the various treatment options for it. I think this is, not a very fun condition to have as a patient, but a little bit selfishly, it's a fun condition for me to treat because we have options that generally are very good and provide high satisfaction and improvement in quality of life for patients. So it really is a satisfying treatment to be able to offer people a satisfying condition to be able to manage because of what we're able to do and offer to help with this. So hopefully these are things that you can learn about tonight. And if it's something you're struggling with, it's something that Urology Associates, we can help you with. So I want to talk a little bit about what stress urinary incontinence is, because it's important to understand how this differs from some other kinds of urinary incontinence that men can have. So stress urinary incontinence, and we may use the term SUI because it's a little easier to say. But this is the type of leakage that you have when your sphincter muscles, so these are the muscles that are squeezing and holding your urine in your bladder. When these muscles do not work correctly, you'll have involuntary loss of urine. And this usually happens when you're doing something stressful. So you may be doing physical activity, you're bending over, you're picking up something heavy. It'll be when you cough or laugh or sneeze and have that sudden rise in the pressure in your belly from that. This is when you have that kind of leakage, that is stress urinary incontinence. And it happens usually because of some sort of damage to the sphincter muscles that are down there. Guys have two of them. There's one that you don't really control. This is a muscle that's there and is always acting to hold the urine in. And then you also have a sphincter muscle that you have a little bit more control over. You can think of this muscle as the one, if you really needed to cut yourself off from peeing at the urinal, you'd squeeze that muscle, and that's your sphincter muscle there that you can control. And sometimes these muscles can get damaged from usually various surgical procedures, perhaps trauma or radiation to the pelvis for certain cancers. This differs from urge urinary incontinence. That's the gotta go right now kind of bladder. That's the kind of bladder when you get the urge to go and you can't hold it before you get to the bathroom and a little bit leaks out. That's urge urinary incontinence. And that's a different problem. That's not usually because your sphincter muscle is not working. That's more of an issue with your bladder. It tends to be more of a problem we treat with medicines as opposed to stress urinary incontinence, where medicines don't always work very well. So probably the most common scenario where we see stress urinary incontinence is after surgery for prostate cancer. And there are studies that show up to 50% of men will have leakage immediately after surgery. My experience, it's probably even a little higher. As soon as that catheter comes out and you're challenged to hold this urine in that you haven't really had to do before, you can see a leakage in a lot of men after a prostatectomy. It tends to get better as time goes by, so that most men will regain a lot of their continence that they had before surgery. But up to 16% of men, so 1 in 6 men, will still have persistent stress incontinence 1 year after a radical prostatectomy for prostate cancer. And if you've still got stress incontinence a year after your prostatectomy, there's really a very small chance that you're going to see a big improvement in your symptoms as time goes by. The reason you develop this incontinence is because of the way the sphincter muscles work. And we'll talk about that in just a little bit. But it's not an insignificant amount of men who suffer from stress incontinence. About 500,000 men are suffering from stress incontinence. And unfortunately, what I often see is men not even being offered, treatment for this after they have surgery, say for prostate cancer, and are living with their leakage or incontinence. And I think there's sometimes anxiety or not wanting to tell your surgeon that, hey, I have this problem here. You're glad the cancer is gone and glad they took care of it. Maybe you don't want to disappoint them, but really it's a problem that you shouldn't have to deal with and live with, and something that we can take care of. So the reason this happens is because of damage to those sphincter muscles that I talked about. So guys, like I mentioned, have two, and hopefully you can see my mouse here, but what we see is you have your prostate here that sits right below your bladder. And then this sphincter muscle is the one I was talking about that you can control when you're trying to cut off your urine. Well, when you have a prostatectomy, or you have a transurethral resection of your prostate, or maybe something like a HoLEP, these things are done for not cancerous conditions of the prostate, but non-cancerous enlargement of the prostate. When this prostate is cut out or removed, that involuntary sphincter muscle that I talked about that's always there and helping to pee in without you having to think about it is gone. So you're left with just this voluntary sphincter muscle, the one that you have to think a little bit more about. When people talk about Kegel exercises or pelvic floor physical therapy, this is what they're trying to help you recognize and or strengthen, so that when you're bending over to pick up the newspaper, if anybody still gets those, or you're, picking up something heavy, this is the thing that you're squeezing to try to help hold the pee in after you've had a prostatectomy. So when those things get injured, it's harder to hold your urine in. And we don't know why some men end up with more leakage than others. You can do the same operation, it feels like, in 2 people, and you feel good, and one guy's dry and the next guy isn't. And there's a lot of data that suggests maybe it's one thing or another, but we really don't exactly know why it happens to one person and not the next. But like I mentioned, about 1 in 6 men can still have urinary incontinence up to a year after their prostate surgery. There are other things that can cause stress incontinence. It's not just a radical prostatectomy for prostate cancer. Certainly trauma can do it. We see a lot of this after car wrecks, motorcycle wrecks especially. You can severely injure your sphincter muscles with a pelvic fracture. We can also see it after radiation for prostate cancer. So that's another cause where we see stress urinary incontinence, especially if you end up having some sort of procedure on your prostate after you've had radiation. It's always more difficult or risky when you have to do something like that after you've had radiation. And then sometimes we'll see neurologic conditions can do it. So spinal cord injuries, spina bifida, which is a congenital condition that can lead to the spinal cord not working or treating the bladder or sphincter muscles properly. We also see it after other causes of other cancers. So rectal cancer is oftentimes a procedure where people will have chemotherapy, radiation, and surgery all done in their pelvis. And these things can injure the way those muscles work and cause the stress incontinence. So unfortunately, I see a lot of men who are really can be devastated by urinary incontinence. I see plenty of men who feel stuck in their house. They don't do anything except maybe go out to church. They don't go out to, see their grandkids play in their games anymore. They don't go to the grocery store because they're worried about leaking and getting their clothes wet and being embarrassed. Or I see people who travel and they want to travel. You finally hit the point in life where you can do that stuff, and you're taking an extra suitcase on the plane with you because it's holding, your pads or diapers that you're having to take with you. And these are, that's not a fun problem to deal with, especially when we've got things that can work and really help improve that. And so, it's hard to promise in surgery, but these are some of the operations where you really can feel good that we can really get people that life back and not feel that they're stuck at home because of their leakage. So what are some of these treatments that we have and what lead to them? So we talked about prostate cancer being the main cause of stress urinary incontinence. So prostate cancer is the most common solid malignancy in men. You see more skin cancers in men, but of solid organ tumors, prostate cancer is the most prevalent one. We see about 70,000 radical prostatectomies done in the US each year. And again, this is the type of procedure that ends up removing one of your sphincter muscles and then may or may not damage the other sphincter muscle that you have in there. So once this prostate is cut out, and then this sphincter muscle has to be sewn back into your bladder, it's really a question of, well, how well is this sphincter muscle going to work? How long was the urethra? How wide around the prostate did your surgeon have to go to feel like they could get a cure of your cancer? How many of these nerves around here were damaged, that not only affect your erections, but may also impact your urinary continence as well? And occasionally you see people develop scar tissue here. They have to have procedures to fix this scar tissue. And then those procedures lead to incontinence that maybe you didn't have before you had to have those procedures done. So it's quite typical to have urinary incontinence right after a prostatectomy when you have that insult or injury to all those structures in your pelvis. Most men are going to recover their continence usually up to a year after surgery. If you have a robotic prostatectomy, there's some literature that says that there's not even as big an improvement after about 6 months. So you really hit your max pretty close to 6 months after surgery, and there's less improvement between 6 months and 1 year. Majority of it you'll do in that first 6 months. We tend to not want to do any surgical interventions within those first 6 months because we see men improve. If somebody comes to me at the 6-month mark and they're just floridly leaky, they cannot hold anything in, they're going through diaper after diaper after diaper, that'll be the earliest that I would do a surgery on someone to fix it. Usually we're going to want to give you time to try to get a little bit of improvement in your symptoms. So what are some of these treatment options that I've mentioned? Well, I first want to say, there are, unfortunately, a lot of conditions that we treat in urology that are easy for maybe some more unscrupulous practitioners to offer care in. Think testosterone, erectile dysfunction. There's a lot of bad medicine out there. I really encourage you, if you're dealing with urinary incontinence, to have that evaluated by a urologist. They're really the only people that should be ever considering doing a surgery on you for this kind of condition. And unfortunately for stress urinary incontinence, there are non-surgical options, but there are not a lot of good medicine options. So if somebody is really driving you down, taking a pill or a medicine for this, and you're not seeing any improvement, it's really because there's not anything great out there. So urologists, obviously we specialize in the urinary tract. Prosthetic urologists, these are folks like myself and others in our practice who've done a little extra training to do some of the implants we'll talk about, to put artificial things in the body. So, heart valves, knees, penile implants, artificial sphincters, these are prosthetics that people get put in the body. And it's important to go to someone who has experience with those, because when you have complications from prosthetics, they're harder to deal with than, say, a complication from a surgery that may not be involving a prosthetic device. So what are the key things that you can do, say, right after a prostatectomy, or even that can be options for short-term usage. Well, certainly I see a lot of men who modify their behaviors. They cut down on the amount of fluids that they drink so that they don't have as much leakage. That's okay. You're not harming yourself, but having to restrict, things you might otherwise drink maybe isn't always the most fun thing to do. Certainly timed voiding can be helpful. So going to the restroom on a more regular basis so that you're emptying your bladder before you get to that point where you might otherwise leak can be a treatment option that doesn't involve a medicine, doesn't involve a pill, doesn't involve a surgery. But again, you're timing yourself around. People come in and they say, I know where all the bathrooms are between my house and your office, or between my house and the hospital, because they're, having to do these planned restroom breaks. I would strongly encourage you, if maybe you've got a radical prostatectomy coming up, or maybe you're fresh from one and you've had one fairly recently, pelvic floor physical therapy is something that can be beneficial to helping you get a return to your continence quicker. Most of our literature doesn't say that pelvic floor physical therapy gets you drier in the long run, but it can get you to your dryness more quickly. Think of these as like a more extensive or more formalized Kegel exercises. Maybe men haven't always heard of Kegel exercises, but a lot of times if they have a female partner, they have heard of Kegel exercises. So these are the things that, like I mentioned before, if you are standing in front of the toilet and you want to cut yourself off from peeing, that muscle that you would squeeze to do that, that's the muscle you squeeze to do Kegel exercises. So strengthening those things, or exercising those muscles, or even squeezing those muscles when you go to bend over to pick something up, can help you maintain a little bit more dryness in that instant. And biofeedback is a component of pelvic floor physical therapy that some can offer to help show you, am I using the right muscles when I'm trying to do these exercises? There are also mechanisms like using pads, using diapers. Most men who are dealing with incontinence know about that. Other catheters can be used. So certainly a catheter into the bladder is an option. I would say that's incredibly low on my list of things that I would recommend anyone do in the long run. We deal with catheters a lot in urology, not just for this kind of incontinence, and there's a lot of risk to long-term catheter usage. If you've had a prostatectomy, it's just like the catheter you had after it. Most men don't want to walk around with one of those for the rest of their life. There are what are called condom catheters. This is what's shown in this picture here. So this is not a catheter that's inserted into the penis, but rather one that is attached to a condom that goes over the penis. So when you leak, the urine will go into a bag, but you're not actually wearing an internal device. And so it doesn't usually cause the long-term issues. The challenge oftentimes with them is getting them to stay on. That can be the main issue for men. And again, you're wearing a bag or an external device. Last but not least, there are penile clamps, like shown here in the slideshow. You can order these for $30 on Amazon. They're called Cunningham clamps or a penile clamp. It's got a soft foam center here, and it clamps just like a vice. Most people hear vice and penis in the same sentence and aren't particularly excited about that. But this can be a short-term option. And by short-term, I mean, you could do it for life, but you can't wear it usually for an extended period of time. If you use one of these, you can only use them for about an hour or so, and you need to give the penis a break, to not be squished by this. So they could be good for going to the grocery store, going to church, walk around the block, whatever, but aren't usually something you can wear all day, every day. It's not, unfortunately, uncommon for me to have men come in and tell me how much it costs for them, to pay for their diapers as well, or pads. Sometimes you can get insurance to cover these with Medicare, but it's not easy. We're all living in our new world of, inflation and supply chain issues, and these are not immune to that. And a lot of people aren't interested, in walking around in this, in addition to the cost. So it's something to keep in mind, while surgery, depending on copays and deductibles and things like that, can be expensive. in that immediate term, sometimes you got to think about the long term as well. And, how much am I paying, for my diapers a year? If you look at some of the literature, it can be $7,000 over 5 years, that you're paying on pads. So something to keep in mind, and when we're thinking about things. The long-term treatment options thing, by this, we mean things that can give you a long-term success. The mainstays are going to be surgical. There is no FDA-approved pill or medication for male stress urinary incontinence. For that matter, there's not really for female stress urinary incontinence either. There are two main things that we use. One is a male sling. Another is an artificial urinary sphincter. These devices work slightly differently. The male sling and the way this works is to help support your urethra. To be honest, people don't exactly know how the sling works. They think they know how it works by maybe moving your sphincter muscles back up a little higher into your pelvis, or maybe making your sphincter muscle a little bit longer so that there's more squeeze in the urethra there. The beauty of a sling is that it works instantly. So when you get it put in, it's going to work right away. The perhaps downside is relative, but a sling is not going to be good for somebody who has really high levels of leakage. If you were walking around wearing 10 diapers a day and really never even pee much because it's just drip, drip, dripping, a sling is probably not going to get you as dry as an artificial urinary sphincter can get. Most men, however, when you look at studies, would prefer a sling if they could, because once it's in, it works right away. There's no moving parts. But it is only good for a more mild to moderate leakage. I would also say that it's not good for you if you've had radiation. In fact, they just published a study last week that I was reading showing that the sling is more likely to fail, more likely to have infection, and more likely to need to reoperation if you've had radiation. I've never put a sling in a radiated patient, and now I have more data to say why. So if you've been radiated, I would discourage a sling. There are urologists who do them, and maybe they have good outcomes for them. I just don't offer the sling for radiated patients. I do want to mention too, for those of you that have a female partner, some people go home and tell their wife, girlfriend, partner, whomever about, I heard about this sling today and it sounds great. And, there have been a lot of bad press, at least in the past, about female slings. This is not the same sling. There is no FDA warning on the mesh that this sling is made out of. It's not been recalled because of that. It's a totally different type of mesh and material and process and the way it's put in. So don't be spooked by that if you see that term or word anywhere. The artificial urinary sphincter is the other main device that we use. This works slightly differently than the sling, and that really this is to try to replace your sphincter muscle that doesn't work well. We don't cut out your sphincter or remove it or replace it, but rather we put this in to try to replicate or copy what that sphincter muscle, the one that you squeeze and hold on to your pee, this one's to try to replicate that. The artificial sphincter is good for all incontinence, mild, moderate, severe, radiated, not radiated. It's good for all flavors. And so the difference is that it has 3 components to it, and you have to use a pump to help make this device work. And we'll go over that in a little bit. So like I said, what's great about a sling is that it works immediately, and there's no moving parts. You don't have to pump anything. It works by itself. So there's nothing else you really need to do. You can go back to usually doing your own normal, regular activities pretty quickly. You're sore after the operation for sure. But in terms of limitations or restrictions, it's really usually I tell people not to pick up stuff real heavy or spread their legs real far apart for a few weeks after the surgery. But otherwise, it works right away. An artificial sphincter, you have to take about a 6-week break after you put the artificial sphincter in before you can start using it. So this component, because it's a little more involved in terms of the incisions that we do and the amount of surgery that we have to do, you got to have about 6 weeks to heal up before you can start using the device. So we would put it in, and you're still leaky for the 6 weeks, and then you'd come back and we would teach you how to use the device and you would start using it. So we have an animation here of an artificial sphincter. So I'm just going to run this here. There's not any sound, but this is a general idea here of how the device works. And I will maybe show some highlights as we go along. But the way this device works is it's got 3 components. So it's got a pump here, and this is the pump that you squeeze to help you pee. So in its resting state, this cuff is wrapped around your urethra like a sphincter, and it keeps your urethra squished at all times. When you get the urge to go pee, you push that little pump that was there, and then it will open that cuff up so that you can then pee, and then it automatically closes itself back up over about 60 to 90 seconds. And so this device, like I said, is trying to replicate how your sphincter muscle used to work. There are a lot of things that we can do to help assess if any of these things are appropriate for you. I would tell you, the main difference, if you're coming in to see me, I'm going to want to know a few things. How much do you leak? How many pads or diapers are you wearing a day? In some cases, I used to even have, I don't do it as much anymore, I would have you bring them in and I can weigh them and I can tell you how much you leak. I'll have you cough in my office. I'll have you squeeze your belly muscles. I'll have you bear down to try to see how easy is it for you to, for me to trigger you to leak, because everybody's different. One guy may wear 1 pad and let it get soaking wet. And some guys may wear 4, but they only get a drop on it, but they just don't like having any sensation of wetness in there. So sometimes it's helpful to be able to do some of these things to assess, well, how much are you really leaking? Keeping a pad journal or pad diary can be helpful. I'll oftentimes use a camera to take a look and see how well does your sphincter muscle work? How well can you squeeze that thing? How long does it look? Do you have blockage in there? These things that can contribute to why you might be having leakage, or which of these things can be better for you in the long run. All surgeries have risks to them, and I shouldn't mislead you and make you think that things can't ever go wrong with surgery. What I would generally tell most guys when I do this operation is I would shoot for getting you 80 to 90% better. I never promise anyone that I will get you 100% dry. I would, but every once in a while we hit a home run and somebody comes in and they're completely out of pads. I saw a sling patient this week who's not in pads anymore. Went out of the country 2 weeks after I did his surgery. I moved his surgery up because he didn't want to take an extra suitcase with him to South America. And he didn't have to. He was sore and he said the plane ride, was a little uncomfortable, but he didn't have to take an extra suitcase with him and hasn't really used any pads since the surgery. But certainly, I would tell you, if you did something real stressful, real heavy, you get out on your jackhammer or your big tractor, you can still occasionally have some leakage. So, but for most guys, they're willing to, take an 80 to 90% improvement in their leakage. What are the risks of these devices? So for all prosthetic implants, concerns are always infection. Fortunately, there's a low risk of infection with these. We give you antibiotics at the time of surgery to try to prevent that. The artificial urinary sphincter is also coated in an antibiotic to try to keep you from getting any infection. And then we clean everything, we wash them out, we do all kinds of stuff to prevent them. Knock on wood, it's quite uncommon to get an infection. With the male sling, there's always a small risk of injury to the urethra or injury to the nerves that go around where we put the sling device. Fortunately, those are also quite uncommon. For the artificial sphincter, because this device has moving parts, these parts can break or spring a leak. And if that happens, we have to fix the device. And the only way to do that is through an operation. So that happens sometimes with these implants where they spring a leak or stop working. Fortunately, that's usually many, many years down the road. There is also a small risk of developing a hole in the urethra from the artificial sphincter. That's called an erosion, where that cuff is wrapped around it. The good news is that's also quite uncommon. The main thing I tell guys is if you go on to get an artificial sphincter, or maybe you have one in already and it's not working right, we'll have you get a medic alert necklace or medic alert bracelet, so that if you ever have something bad happen to you and you're brought into a hospital and you can't, tell the docs, hey, I have this thing in, you don't want a catheter put in you willy-nilly without deactivating this sphincter device. So it's important to know or to be able to communicate to your healthcare providers that you've got this device in, should anything ever require you to have a catheter put in and you can't speak for yourself. In terms of insurance coverage, unfortunately, I feel like insurance rules healthcare these days. But generally, I would tell you that it's quite uncommon for insurance to deny these. Of course, we can never, guarantee that because everybody's plan is different, but we will always check with it and, make sure that insurance will cover it before we do an operation, or at least get an idea of what we call predetermination or prior authorization, where your insurance company has said, hey, yes, we will cover this procedure. So in summary, male stress urinary incontinence, it's a known side effect and unfortunately not an uncommon side effect of prostate cancer treatment, as well as radiation trauma. There's a lot of treatment options. There are certainly non-surgical options that can be helpful for men and improve their quality of life. The surgical options that we have, I think, work really well and can be helpful, and are certainly something worth considering if you're struggling with urinary incontinence. I'd really encourage you, if you have a urologist, to talk to them and see if they can offer this for you, or if not, get you to someone in our practice who takes care of it.